next case. Okay. Okay.
All right, so this is our next case. So this is a 10-week-old with umbilical hernia. So that was the requisition written in the requisition of the ultrasound, and this was an outpatient coming to us from a family doctor. And this is the cine clip of the hernia. Sorry, let's see if I can go back.
Okay, yeah.
So just one more for you guys to see. Okay. So do you think this was an appropriate indication? Yes or no?
Yes, 15 seconds. So the indication of ultrasound, right?
Correct, yeah.
Okay. All right. Okay, so the result is A, yes.
Okay.
69%. B, 31%.
Okay. So that's interesting because in fact, we don't need to image umbilical hernias unless there's signs of complication. Why? Because the surgeon is very easy for the surgeon to make the diagnosis of an umbilical hernia and what is the size of the defect. They can just palpate the defect and estimate the size. So throughout the study, that's what happened. The technologist gave initially this image, and then afterwards, she came back with this image. So what do you think happened between these two images? So you can vote now. So the sonographer imaged a different area, the hernia reduced. There's not a hernia, it's a tumor actually, or none of the above.
Right, so.
Yeah, exactly right. So the hernia reduced. So if you go back to that image, if it goes back. Not working here.
Yeah, yes, okay, yeah.
So basically what the technologist did is she applied pressure, and then all this air-filled bowel that was inside the hernia sac went back to the abdominal cavity, and all we are seeing now is the empty sac and in this slightly thickened wall. But this is not a tumor, right? And it's not incarcerated. So this information is very important, right? Because you don't want to send home a patient that has an incarcerated hernia. But the fact that it is reducing is reassuring. And this reinforced the fact that this study is not really appropriate because the hernia was not even incarcerated for us to be imaging. The reason that we image an umbilical hernia with signs, clinical signs of incarceration, is because you want to make sure that the bowel or the whatever content is inside is not ischemic, right? It's not suffering strangulation. So this is actually not an indicated study. Okay, let's see if we can bypass this.
Yeah.
There we go. Oops. Okay, so when do we need to image then an umbilical hernia? Well, if there's pain in the hernia, if there's any tenderness, swelling, or discoloration of the hernia, if there's an inability to reduce the hernia, so if it's incarcerated, or if there's signs of bowel obstruction, right, vomiting or abdominal distension. So what is the surgeon going to do with this information? So most neonates are born, like they are born, they have the umbilical cord, right, which is clamped, and that defect usually closes by its own. Some babies, it does not, and then that's how the hernia develops. However, even when you do have an umbilical hernia in a neonate, most of these defects will close by itself. So it's not until 2 years of age that they will reassess if there's no symptoms of complications, obviously, to decide if they need to do any surgery or not. So if they don't notice any change in size in terms of decreasing the defect by age of 2, or if the defect remains 1.5 or more centimeters, they might then consider doing surgery in this hernia by then. The other possibility is if the defect doesn't disappear by the age of 5, then the surgeon will also correct. And obviously, if it becomes incarcerated or any other complication, then they will do surgery. Otherwise, they would just observe and reassure the parents that that's actually fine and, you know, they are not worried about it. So case number 5, 6-week-old female, colic and crying. The bowel was palpated in pelvic area, and they wanted us to assess for a hernia. So this is what we saw. Okay. So what structure do you think it's herniating? Let's start voting. So A, bowel, B, a lymphatic malformation, C, the ovary, or D, there's actually no herniation present.
This is an easy one too, Nina.
Okay, so good.
Let's see. Yeah.
Awesome.
Yeah,
exactly.
my guys are really good in ultrasound, not like Canada.
That's awesome. So yeah, so in female patients, right, like it's rare, but you can have the ovary herniating through the inguinal canal. So how does that happen is actually an embryological remnant, which is called the canal of Nuck, which is supposed to obliterate in fetal life. But because in some patients it remains open, then it allows bowel or the ovaries to herniate through the inguinal area, which will then be an indirect hernia. And there's a risk that the ovary can become incarcerated and even torch in the inguinal region. So it's recommended surgery as when you see that. It's not an emergency if the hernia is reducing, but if the ovary is incarcerated, obviously it needs to be treated as an emergency. And remember that it can develop encysted hydrocele there too, because the canal of Nuck, it's nothing but a fold of the peritoneum, which is equivalent to the processus vaginalis in man. And so fluid from the peritoneal cavity can in fact become encysted in the canal as well. So sometimes you're not going to see ovaries or bowel, you're just going to see a cyst in the inguinal canal region. So just bear in mind, and again, usually inguinal hernias are imaged only if there are signs of complications, because the surgeon can make the diagnosis clinically. All right, so we'll see. Maybe this is a too easy one, Ali. We'll bring harder cases next time.
We'll see. Okay.
So this one is a 17-year-old presenting for follow-up of thyroid nodule. So this is sagittal image of the right thyroid lobe and the sagittal image of the left thyroid lobe. So what is the most likely diagnosis for this one? You can start voting. So would you think that this is an infiltrative tumor, or are we dealing with multiple thyroid 4 nodules? Is it a thyroiditis, or none of the above?
Okay. Number of voters are increasing. Good. So.
Awesome.
Yeah.
Too easy. I'm
Yeah.
gonna increase the level of difficulty for the next.
Yeah.
Awesome. Okay, so yeah, like what we are seeing here is what is called the giraffe pattern. This is not the most typical presentation of giraffe pattern, but it does look very similar as well to what is shown on this case from the literature. So usually these pseudo nodules are around 0.5 to 1 centimeters. They're not so big. Most of them will have ill-defined margins. But they are treated and interpreted as pseudonodules. They're not really supposedly to be called nodules. And as you can see, even in color Doppler interrogation in this particular case, it's interesting because most of the hyperemia we're seeing are focused on these areas where the parenchyma looks more abnormal. And permeating these abnormal areas, we have normal thyroid that doesn't look hyperemic. So yeah, so this is usually Hashimoto's or chronic lymphocytic thyroiditis.
Okay.
Okay, so hopefully, Ali, you're gonna have more challenges.
Okay, so I'll start. That was a really good case because I've seen many times before people calling those nodules as those lesions as nodules, especially in the parathyroid gland as well. I mean, in the
Well,
parotid gland.
it can be hard.
Parotid,
When you're
yeah.
scanning, it can be really hard to differentiate from a real nodule, right?
Yeah, okay. So my question already started. People are voting. So the question is, which one requires an ultrasound? This is a patient with dimple, and this is another patient with dimple. Do you do a spinal ultrasound for this one, or for both? So people voted, and the answer is B. So you would do an ultrasound for this patient only, and it's correct because this looks like a simple, and this looks like a risky dimple because the dimples are categorized into two, as you can see, low risk and high risk. This is a low risk one. It's in low position, very close to the anus, within 2.5 centimeter, smaller than 5 millimeters. It's in the midline and it's not associated with skin lesions. However, if you look at this, there is this inverted Y appearance. This is usually associated with spinal dysraphism, and it's very high in position. It's more than 2.5 centimeters. And so this is a complex. So this needs an ultrasound and this doesn't need an ultrasound. This is according to these practice guidelines, ACR, SPR, all the societies that you can think, they are all agreed on this. This doesn't need an ultrasound. But in real life, we see all the time in Turkey, in Canada, if they see a dimple, they ask for an ultrasound to make sure. But what this information gives us is when you are scanning a patient like this, just look at the dimple. And if you think that it's simple, then it's going to be a normal study. You can reassure yourself. And the trick is, if you need to use your fingers to see the dimple, then it's usually a low risk one because it's in the intergluteal cleft and you need to use your fingers. But if it's too high, you can see it without using your hands and it's high risk. And what happens is actually in this, it's the high ones are risky, the low ones are not risky because the dural sac ends at the level of S2. So whatever below S2 is usually not connected with the dural sac. So they don't cause problems. Here in this one, there's a dimple and it's associated with a low dimple and a tiny sinus, but this one is high and there's associated lipoma, intradural lipoma. So let me tell you more. So the risk when there's a coccygeal dimple at the level of the coccyx here, and it's usually the risk is almost none, very, very low. That's why we don't need an ultrasound. It's just a coccygeal pit. It's called pit, and not even a dimple. It's at the sacrococcygeal region, they call it a pit. If it's a sacral dimple, it's at this level, at the level of the sacrum, then the risk is increasing, but not as high as the highly located dimples above the intergluteal sulcus. And here is an example. This is a high dimple associated with a skin lesion. It's in the midline, but it's very high. And if you look at the level, it is way above the level of S2, and it's connected with a real dorsal dermal sinus. And this patient had some tethered cord symptoms. So my question, what is your diagnosis? These are ultrasound studies, spinal ultrasound. It's a newborn presenting with dimple at birth, normal neurological exam. And here is the question, you can vote now. Is this a dorsal dermal sinus tract? Is this sacral agenesis? Is this caudal regression syndrome? Or is this a dysmorphic coccyx? Open to voting. 13. I will stop when it reaches to 30. So 25, 32. Okay, good. So the answers are A, dorsal dermal sinus tract, and D, dysmorphic coccyx. So this is very common. After the introduction of spinal ultrasound, we started doing more and more ultrasounds. And then these patients were called as like dorsal dermal sinus tracts. And this is a little bit overcall because this was a dysmorphic coccyx. This is a dysmorphic coccyx. What I mean is the coccyx is angulated anteriorly to the skin surface, and it usually reaches to a dimple at that point. And because it's cartilage, it is hard and usually palpated, and there may be some associated lesions as well. So this makes people worried because it is palpable, and they ask for an ultrasound. And at the ultrasound, when we see this, sometimes we call it a dorsal sinus, then it may, everything becomes more complicated. So normal coccyx is usually formed of 4 or 5 vertebrae. The first one is usually ossified at birth. You can see it on the X-ray or the ultrasound. This is the normal configuration of the coccyx, but there may be variation. It may be a little bit more convex. It may be shorter than usual, and for example, here it's more angulated. So, but these usually don't cause any problems. When they extend to the skin surface, they are palpable, and then people are worried. And here is the dysmorphic coccyx. It's usually extending posteriorly to the dimple, to the area of the dimple. And very commonly, we can also see an associated tract, which is associated with the coccygeal pit as well. But this tract is usually extending to the tip of the coccyx like this. There may be associated dysmorphic coccyx or not, but these sinuses usually don't cause much problems. And these are very low, and this is just coccygeal pit and not associated, most of the time, not associated with spinal dystrophism. And you shouldn't be overcalling these. So this is a real one. This is in high position, and you can see it nicely. It's at the level of S2, not coccyx. And this is a real dorsal dermal sinus. So take-home point is, dysmorphic coccyx as an isolated finding is usually incidental and does not require further investigation. Okay, so I'll skip to my next case. This case is a 2-year-old female with 13 millimeter pineal gland cyst. As you can see, no symptoms, normal neurological exam. And here is T1 sagittal post-contrast, and T2 and diffusion through the lesion. So my question is, what is your diagnosis? You have 15 seconds to vote. Is this a simple pineal cyst, pineoblastoma, germ cell tumor, or pineocytoma? Okay. I have 30 voters. Let's see the results. As I expected, yeah, most of you knew it. It's not a pineocytoma. It is a simple pineal cyst. And so a normal pineal gland appears just posterior to the tectum. It has an ovoid shape. It enhances and appears better on the T2 like this. It's normal. And sometimes the shape, there may be variations in the shape like this when associated with calcifications. And they may show some enhancement in the periphery. So this is like a rim enhancement, but this is a normal gland. And there is no mass effect, as you can see. So when this is another case to show you the natural history. So this 2012, there was a tiny cyst here, and then it grows. After 5 years, there is an increase in size. So, and then it becomes stable over 2 years. So this is usually the most common natural course of these cysts. They may show some fluctuation, especially in children. They may show some increase in size, but still they usually don't cause much problems. It is very common, up to 40% in adult autopsy series, and there is the presence of a septation is very common, up to 74%. So here's, for example, a tiny septation that we can barely see. This doesn't make this cyst a complex cyst. This is still a simple cyst with a septation. And another case, still 5-year follow-up, it is just growing a little bit, but it is not causing mass effect or any problems. So shall we do a follow-up? So this is an article in Radiology. They recommend not to do follow-ups unless there are related clinical symptoms. And I spoke to our oncologist and neurosurgeon before this meeting. They agree with this. The oncologist mentioned 10 millimeter rule. So he says that if it is above 10 millimeter, I do a follow-up for once. Then if it is not changed, I wouldn't continue. The surgeon doesn't even follow the numbers, and he's usually not very worried. And both of them, they are very experienced. They haven't seen any case, simple pineal gland cyst turned into a tumor or a hydrocephalus in their career. So that's what my experience is as well. So why are we afraid of? This is the differential. This may be an epidermoid cyst. So, but we can tell if it's an epidermoid cyst almost 100% by doing a diffusion imaging. This may be an arachnoid cyst. This is an arachnoid cyst pushing the gland posteriorly that we detected antenatally and did a follow-up, and it didn't change much. And it didn't cause mass effect, but this patient needs follow-up for sure for the development of hydrocephalus. This was a cystic germ cell tumor. Germ cell tumors are almost always solid, but they may show some cystic degeneration. And here you can see, actually I'm showing the most cystic looking component to convince you, but it's really difficult to call this as a simple cyst. I don't think it's possible. The only tumor that can mimic really a simple cyst is a pineocytoma. And I searched for the literature. This is the best one I could find that could mimic the simple cyst, but still it is showing a very strong contrast enhancement. And their conclusion is most of the pineocytomas are at least partially enhancing masses that may contain areas of cystic change or at least nodularity in their walls, which should not be confused with typical pineal cyst. So what my conclusion is, if you do a contrast enhanced MRI, if it's a simple cyst and there are no symptoms, the patient may be just sent home and tell them that if you have any symptoms, come back. But otherwise, there may be a maximum a 1-year follow-up. Then if everything is fine, the patient may not need any follow-up MRIs again. Okay, I showed this case because this was a common practice to do MRI follow-ups in Turkey, and I see this in Canada as well. That's why I'm showing it. Maybe we can have a discussion at the end. Okay, so another case, my last case actually is an ultrasound, a newborn. What is your diagnosis? Is this a congenital cyst, germinal lytic cyst, PVL, or choroid plexus cyst? And you're seeing the ultrasound images.
I think they will get this one too, Ali.
Yeah, I'm pretty sure. Okay, let's see. Yes, yeah, most of them, but we still have some waters, 11 waters. Didn't think so. So, but this is common. I see people calling this PVL all the time in my daily practice. The first thing is the patient is clinically well, and there is no history of HIE. And here you see the cysts along the frontal horns and the anterior aspect of the body of the lateral ventricles. And they're elongated cysts, and you most of the time bilateral and parallel to the course of the ventricles.
And I think also like another factor is the fact that it's a 6-day-old, right? Like to be a PVL, a cystic PVL with this appearance in a 6-day-old, it would have to be something starting intrauterus.
Definitely. And this is anterior, right? Not posterior PVL.
Well, yeah, I mean, you can still have cystic preventricular accumulation in the frontal lobes, but yeah, like it's usually later on, right? Like this is probably the first ultrasound the 6-day-old had. It would have to be something intrauterus to have the cysts already, I guess.
Definitely. And what happened to this child? We did a follow-up, we did MRIs. MRI, we can see the cysts, and this child had a 7-week follow-up, and we don't see the cysts anymore. And these are, yeah, developmental cysts and disappeared. In the differential, you should consider germinal matrix hemorrhage, but most of the hemorrhages are within the first 3 days, as Nina mentioned. So, I mean, Nina mentioned the timing. So you should start seeing the hemorrhages within the first 3 days, most of the time. And these are the germinal matrix hemorrhages. As all other hemorrhages, they appear hyperechoic in the acute phase, then they become, during the evolution, they become more hypoechoic, and then they may show cystic changes. They don't have to, they may just disappear, but they may show some cystic changes. And this is 9-week follow-up, and it's still there with some cystic changes. It's in the caudothalamic groove and subependymal, as you can see. The other differential is a germinal lytic cyst. It is, the name comes from the germinal matrix, and it is at the region, it is still at the same region related to the germinal matrix at the caudothalamic groove, subependymal. It is not hemorrhage, we can tell because we have the SWI-MR, and it's a complex cyst with some septations. You can see them on the MRI as well here. These cysts are not as benign as the previous one because they may be associated with some paroxysmal disorders, they may be associated with CME, but most of the time they just disappear without any ominous findings. Okay, the other differential, as Nina mentioned, white matter injury of prematurity, with the new name, former name is PVL. And here, this is the follow-up. We don't see the cystic changes within the first 2 weeks. It's very uncommon. The cysts usually occur around after 2 weeks, around 4 weeks old. And this is confirmed with the MRI as well, and predominantly affecting the posterior, but also involves the anterior. And CMV, we saw a CMV patient presenting with periventricular cysts here, and this was also associated with ventricular striate vasculopathy and multiple extensive polymicrogyria. And the other is choroid plexus cyst. If it is in the location of the caudothalamic groove, then it may be difficult to differentiate from others. But if you do an MRI, you know that it's not hemorrhage. And they are usually common in the prenatal life. We see them, if they are isolated, they usually disappear. They are not associated with anything if they are isolated. But if there are associated malformations, especially cardiac, then you should consider trisomy 18, but it's rare. So they usually disappear. It may be difficult, but even if you don't differentiate from others, the clinical significance is not that important. And so to summarize the neonatal cysts, germinal tick cyst, PVL, CMV, connatal cyst, germinal matrix hemorrhage, evoluting, and choroid plexus cyst. All right, so take-home point is connatal cysts are benign developmental cysts and do not require follow-up. All right, so thank you for attending. We presented 10 cases today that we think is important.
Thank you very much for these great cases. It was a great presentation, and we could find many tips in it we could use in our everyday practice. I personally found answers to many of my questions during, my everyday ultrasound practice. And so we have many participants from many different levels in this presentation. We have general radiologists, radiology residents, pediatric radiology trainees, and experienced pediatric radiologists. So thank you very much for these different levels of difficulty in the presentation. We appreciate that. So everybody could find something to take home in this presentation. And thank you once again for useful practical tips. And there are a few questions. So one of our participants asks, how do you decide whether or not herniated ovary is torsed? To Nina Stein.
Yeah, so the signs, the ultrasound signs of ovarian torsion in not necessarily herniated ovary, right? But like, let's say it's a female with pelvic pain and they want you to rule out ovarian torsion. So first of all, you want to make sure that the ovary is actually sitting in the anexa region. So if that ovary is sitting, for example, behind the uterus or in an atypical location, that is a red flag. Then you have to look at the overall size and the echogenicity of this ovary. So if it's heterogeneous and swollen, like enlarged, then that's also a red flag. So the color Doppler, obviously, if you don't see any color, then you know that that ovary is torsed, and that's what it is. And you can make the final diagnosis. But sometimes you have to remember that you can have situations where the ovary will be torched and then detorched and then torched again. So it could be an intermittent process. And you can actually pick up this patient in a moment where the ovary was torched an hour ago, but now it's not torched anymore. And then what happens is the parenchyma of this ovary will be very, very low resistance because it's avid for blood and oxygen. So you're actually going to have a hyperemic ovary with low resistance index. So that's also a sign that you could raise in a swollen ovary, heterogeneous ovary, hyperemic. That's probably a torsion detorsion. Obviously, you have to correlate with clinical history and make sure this patient doesn't have an inflammatory pelvic disease, for example. Now, in the case of the hernia, most likely the ovary will first be incarcerated and then potentially get torched. So because it gets swollen, usually it's stuck in there. So clinically, you're going to have a very painful incarcerated hernia. And then if you put your probe in there, you probably will see an ovary that is also enlarged, heterogeneous, and the amount of flow you're going to detect in the color Doppler and Doppler interrogation will vary depending on how bad is the blood supply cut off. So just keep that in mind that, if you have an enlarged ovary with heterogeneous appearance inside a hernia sac in a female baby, even if you do see a little bit of flow, if the patient has pain and it's swollen, you want to have the surgeon looking at it right away.
Thank you so much. Another Attendee asks, what is the difference between congenital and subependymal cyst? To Ali.
So
Do you want to go back to the images, maybe?
no, I think that's fine. So congenital cysts are within the parenchyma, within the most frontal lobes, periventricular white matter. And subependymal cysts, I think it's a definition by location, subependymal. It's not a specific type of cyst. It's just any cyst can be subependymal by location. But congenital is like a developmental cyst within the white matter. So I see this differentiation in the hemorrhage as well. Sometimes they call it germinal matrix hemorrhage, sometimes subependymal hemorrhage. For example, grade 1 is usually, you can call it, the neonatologists usually call it a subependymal hemorrhage. You can also call it germinal matrix grade 1 hemorrhage. And subependymal is, I think, just by location.
Mhm. Thank you. And there is another question, this time for Nina. What is your recommendation for portal venous gas without any additional finding or history of NICU catheterization? Our attendee had 2 cases of isolated portal venous gas that worked themselves out without any treatment on control ultrasound following week. So he is wondering what's the recommendation in this condition.
Yeah, it's interesting. Very good question. So the experience that we have, and I had as a fellow in sick kids, and my current practice in McMaster, is that I feel ultrasound is a much more sensitive method than X-ray to detect portal venous gas and even pneumatosis sometimes. So if you have a case of bowel perforation, I had 2 cases where I actually was able to detect it much earlier using ultrasound and detecting a very small pneumoperitoneum through ultrasound than X-ray. And in one case was actually very interesting because the surgeon didn't believe on me, and they decided to wait a few more hours and repeat the X-ray with a lateral decubitus instead of a shoot-through view of the neonate. And then what happened is, like an hour later, they did the lateral decubitus view, and they didn't see any free air in the X-ray, and they thought, oh, like Dr. Stein is overcalling this ultrasound, this kid is fine. Obviously the kid was very sick, but they didn't think the kid had perforation. And I said, I think you guys probably are misinterpreting this X-ray, because once you put the patient in lateral decubitus, the tiny bit of air that was sitting anteriorly in the abdomen will have to travel all the way to the flank. So how long have you left this child in lateral decubitus before you took the X-ray, right? And turns out that they obviously, because the baby is very sick and can't tolerate changes in the decubitus, they just put the kid in lateral decubitus, took the X-ray, and immediately put the kid back on supine position. So it turns out that 8 hours later, they repeat another X-ray, and then obviously there's frank pneumoperitoneum in the X-ray. So my experience is that ultrasound is more sensitive. Now, if it goes away by itself, I wonder, like what is going on clinically, because it's very unlikely that you're going to have a case of pneumatosis, for example, going away by itself. Like if it was, for example, in our case, which it was a pyloric stenosis, which is a more benign pathology than necrotizing enterocolitis, I can understand how the gas could potentially be intermittent. But if it's a necrotizing enterocolitis and you have a segment of bowel that is dying, and that's why you're getting the air through the wall into the liver, then it would be odd. So I don't think I can answer completely your question. I think I would need more of the clinical history of the patient to try to correlate and understand.
Thank you so much. There are like a billion thank you notes in the chat box, and everybody thanks for this great presentation. And some of our participants want to know if they can reach this recording afterwards, Ali. Partially,
yes,
maybe.
yes, it will be on YouTube channel, but we forgot to start in the beginning. So, but most of them will be on our YouTube channel. Follow us, like it, share it.
And please don't forget to fill out the feedback forms. And next presentation will be from the team of Ukraine Children's Specialized Hospital from Ukraine, Kiev. And today, I think we don't have any more questions, and we can close the meeting. Thank you very much for your time, and we appreciate spending your lunch time for us, Nina and Ali.
Happy to do so. Thank you so much. I hope people had fun, and it was a pleasure to be with you tonight.
It was very fun. Thank you so much.
Fantastic. Thank you.
Thank you. Thank you. See everybody in 2 weeks, hopefully. Good night.
Good night. Bye-bye.
Ismail.